Well, hello, everyone. Thank you so much for coming tonight. We are thankful that you chose to come here. You could have done anything tonight. You could have stayed home in your pajamas and relaxed. Um, and so, for you guys to come here and take the time, we really do appreciate it. My name is Maggie Weidinger. I am the physician and APP relations liaison. So, what that means, that's a long title. That means my job is to connect our physicians and our advanced practice professionals to one another, but then also within the community. And so this is part of my job is being able to organize community health education. And so tonight, we're so fortunate. We have Dr. Leila, and I always get stressed out that I'm going to say her last name wrong, but I don't think so. Noghrehchi.
You got it.
Oh. She's one of our new primary care providers, physicians, and we're so lucky to have her. She's only been here 6 months, okay? And she has the most adorable little one. She's a new mom, so that's always fun. And she has just worked really hard to integrate herself into our community, her family. Her family's been a part of our community for a while, and being able to share different information. She prioritizes your personal goals and then also cultural backgrounds, which I think is so important. You know, making sure no matter who you are, you feel like you're well taken care of. She listens very carefully. I can attest to that, and is really good about explaining. And as you see in her presentation, just the medical background of what she's seeing and what she's dealing with. So I won't take up too much time. The one couple house rules that we do have is we always love questions. We want to engage in conversation with you. And so we will have the opportunity to take questions towards the end unless Dr. Noghrehchi changes her mind and says answer whenever. But if you do have a question, as you see, there are these boxes on all the tables. These are your microphones. So on the bottom it says push. If everybody will just practice pushing on it, and you'll see a little green light will pop up at the top. That's how you know it's on. You don't even have to do anything else, just talk. When you're done, just push and it turns off. So make sure you push that button and use that microphone so that our guests online can also hear that question and be in part and engaged in that conversation as well. All of you online, we're so thankful that you joined us online tonight. And again, the same thing, you have the freedom to pop in a question in that question or chat bar anytime. And when it is appropriate and when the time comes up, we will answer that. I will speak for you and ask those questions at that time. When you do ask questions, think about questions that are for the whole of the group and not specifically to you or your situation, only because that information is usually information you want to talk to your primary care provider with. So we want to kind of make sure that we keep that time and those questions, that information is protected for you and for the community. So when you're thinking of those questions, try to think of questions that can really relate to the whole, if that makes sense. Without any further ado, here we go.
I don't need that one, I don't think. All right, thank you for that introduction, Maggie. I appreciate it. Good evening, everyone, and thank you so much for joining me. It's so nice to see so many familiar faces. And for those of you who I have not met, I'm Leila Noghrehchi. I'm a family physician at Northern Arizona Healthcare Primary Care in Flagstaff. It's always like a little bit of a mouthful. So tonight we're going to talk about sleep, and hopefully you'll get to walk away with knowing a few more things than you walked in with. Now, I want to be upfront right away. Despite the name of this lecture series, Meet Our Experts, I am not a sleep specialist. I don't run a sleep lab, and I'm not here as the world's leading expert on sleep. But here's the thing. For most people who are struggling with sleep, someone like me is the first stop. Family doctors and primary care providers are where a vast majority of sleep concerns are raised and addressed. We see it every single day. I have this conversation multiple times a week. So while Thanks. So while I'll always refer to a specialist, which we do have, when that's the right move, the reality is that a great deal of sleep trouble can be recognized, understood, and treated right in your primary care provider's office. That's exactly why I wanted to talk with you tonight. Okay, so here's our plan for tonight. We're going to cover 3 things. First, what insomnia actually is and how you know if you have it. Second, and this is the most important part, what you can do about it, including some newer tools you can use right from your phone. And third, when medications make sense and how your provider can help. I'll keep it to about 30 minutes and then we'll have time for questions at the end, if that's all right. All right, so let me just start with a quick question. By a show of hands, how many of you have had trouble sleeping at some point in the last month? Thank you. By visual representation, you're not alone. About 1 in 10 adults have what we call an insomnia disorder, and that's the ongoing serious kind. And another 15 to 20% of adults have occasional sleep problems. It's more common in women, in older adults, and in anyone dealing with other health issues. And poor sleep isn't just a personal struggle. It affects those around us too. A study found drivers with insomnia were 33% more likely to be in a crash or near crash than drivers without a sleep disorder. The America Insomnia Survey found fatigue was a reported factor in 15 to 20% of traffic accidents generally. And a study of truck drivers found insomnia nearly doubled crash risk and more than tripled near miss risk. Drowsy driving can impair you much like alcohol does. And that's just one example of how your sleep troubles can affect those around you as well as yourself. So what actually counts as insomnia? It's not just about having one bad night. Insomnia means having difficulty falling asleep, staying asleep, or waking up too early. And importantly, having daytime problems because of it, such as feeling tired, having trouble concentrating, or feeling irritable and on edge. When this happens at least 3 nights a week for 3 months or longer, we call it chronic insomnia. Now, I want to be clear about something. The occasional bad night of sleep is completely normal. Everybody has them. Insomnia is when it becomes a pattern, that it starts affecting your days, not just your nights. So that brings me to a key point. Insomnia is not just a nighttime problem. Yes, at night you might lie awake, toss and turn, or wake up over and over, but the real toll shows up during the day as low energy, trouble focusing, mood changes, strain on your relationships, and even a higher risk of accidents when driving, like we talked about before. And over the long term, poor sleep is linked to depression, high blood pressure, and other chronic sleep health problems. So treating insomnia is not just about feeling less tired. It's about protecting your overall health. So how do we diagnose insomnia? Here's some good news. In most cases, it doesn't require any fancy tests or scans. Mostly it's a conversation. Your provider will ask you about your sleep patterns, your daily habits, and how sleep is affecting your life. One of the most helpful things that you can do is keep a sleep diary for about 2 to 4 weeks. Just jot down when you go to bed, when you wake up, and how you slept. Bring that to your appointment. It tells us a lot. In this slide, I've included an example 2-week sleep diary. It can look a little bit overwhelming. This is the one that's provided as a template from the American Academy of Sleep Medicine. But I tell people, however you're comfortable writing down these notes, your provider would be more than equipped to review that with you. For plain insomnia, blood tests aren't usually required to make the diagnosis, but your provider may order some tests based on your medical history, because a few common medical problems can masquerade as or worsen a sleep problem. For example, your provider might order a thyroid test called a TSH, because an overactive or underactive thyroid can affect your sleep. Iron studies, including a ferritin level, especially if you have that kind of creepy, crawly, need to move feeling in your legs at night, which sometimes points to restless leg syndrome, and it's often tied to low iron. A blood count to check for anemia, and sometimes blood sugar, vitamin D, or vitamin B12, depending on your other symptoms. The point isn't that everyone needs a lab draw. It's that if something in your medical history hints at an underlying cause, sometimes a simple blood test can uncover it. And there's one more thing we always want to make sure of before settling on insomnia, and that there isn't another sleep disorder hiding underneath. And that's where sometimes our sleep specialists can come in. The biggest one to rule out is sleep apnea. So let me spend a few minutes on that because it's incredibly common and very often missed. Sleep apnea, the most common form is called obstructive sleep apnea, is when your airway partly or fully collapses over and over during the night. So your breathing actually stops and starts. And each time your body has to briefly wake up to breathe again, sometimes hundreds of times a night, usually without you even knowing it. And this is really common. It's estimated to affect close to 1 billion people worldwide, and a huge number are undiagnosed. So, how do you know if this might be you? The classic signs are loud habitual snoring, the kind that you can hear through a closed door. Someone telling you that you stop breathing, gasp, or choke in your sleep. Waking up unrefreshed, no matter how long you were in bed, and being sleepy or foggy during the day. Other clues are morning headaches, waking to urinate several times, and needing to nap. Now, you don't have to have all of these to qualify as somebody with sleep apnea. Sometimes you can have one, sometimes you can have some, and in some cases you can have none. But the biggest risk factors are being overweight, having a larger neck size, high blood pressure, being male over 40, though women get it too, especially after menopause. And here's why it matters beyond feeling tired. Untreated sleep apnea is linked to high blood pressure, atrial fibrillation, which is an abnormal heart rhythm, and other heart problems, strokes, and diabetes. So this is really one that we don't want to miss. So how do we sort this out? In the office, we often start with a simple screening questionnaire that asks about snoring, tiredness, observed pauses, blood pressure, and a few body measurements. It's a quick way to flag who's at higher risk. If your risk looks high, the next step is an actual sleep test, and there are two kinds. One is a home sleep test, a small kit that you take home and wear for a night or so in your own bed, which is a convenient and lower cost method and works well for straightforward cases. The other is an in-lab sleep study called a polysomnography, which is the more complete gold standard test when the picture is complicated or there are other health conditions. This is exactly the point where, as a family doctor, I'll often bring in a sleep specialist. Now, the good news, treatment works and it can be life-changing. The main, most effective treatment is called PAP therapy. That's the CPAP machine many of you are probably familiar with. Either you've got family members who have them or friends who use them. It's a small bedside machine with a mask that gently blows air to keep your airway open while you sleep. When people use it regularly, snoring stops, sleep becomes restful, daytime energy comes back, and blood pressure often improves. The mask takes some getting used to, and that's normal. There are many mask styles, and your sleep team or your primary care provider can help find one that's comfortable. And there are alternatives for people who can't tolerate CPAP. A dental device called a mandibular advancement device that moves the jaw forward, weight loss, which can significantly decrease the severity of your obstructive sleep apnea, sleeping on your side instead of your back, and for select patients, surgical options or a nerve implant. Okay, so let's come back to insomnia itself, assuming sleep apnea has been ruled out or addressed. When people think about treating insomnia, they usually think of a sleeping pill. But here's what might surprise you. The best first treatment is not a medication. Every major medical guideline recommends something called cognitive behavioral therapy for insomnia, CBTI for short, as the first line treatment, not pills. Why is that? Well, because in the long run, it works better than medication. It has fewer side effects, and the benefits last even after you finish the program. If you take away one thing tonight, let it be this. Once you start on a medication, there's a possibility that you will rely on it for a very long time. I've included this chart here that has a lot of words, and I usually try to refrain from that in presentations, but really it's just supposed to represent the comparison between CBTI and sleep medication in the short term versus the long term. You can see in the short term, they're very similar in terms of their effects. They both reduce time to fall asleep, reduce nighttime awakenings, and improve sleep quality. However, in the long term, they're vastly different, and CBTI is significantly superior in the way of maintaining benefits after treatment ends. It has a better remission rate and no side effects after treatment. And then this is just another visual to sort of drive home the point of the comparison in the short term versus the long term of CBTI versus medications. The bottom line is in the short term, both work equally well. In the long term, CBTI always wins, and the benefits last after treatment ends. So, what is CBTI? It's a structured program over a few weeks with 5 main pieces. First is stimulus control. This means that your bed is for sleep only. If you can't sleep after 15 or 20 minutes, get up, go to another room, do something quiet and boring, and come back when you're sleepy. We're retraining your brain to link the bed with sleep. Second is sleep restriction. And this one might sound strange, but we actually limit the time that you spend in bed for a little while to match how much you're really sleeping in it. It's counterintuitive, but it's one of the most powerful parts of CBTI. Third is cognitive restructuring, changing those anxious thoughts like, if I don't get 8 hours, I'm going to be a wreck tomorrow. Those thoughts keep you awake. Fourth are relaxation techniques, deep breathing, muscle relaxation, mindfulness. And fifth is sleep hygiene, a consistent wake up time, avoiding caffeine and alcohol near bedtime, keeping your room cool and dark, and putting the screens away. These are the ones that I think most people are familiar with. But sleep hygiene alone isn't enough, and it works best as part of a full CBTI program. I'd like to, for a minute, just take a pause kind of midway through our presentation and try one of these relaxation techniques if you haven't ever done it yourself. So when you're ready, I'd like you all to lower your gaze or close your eyes if you feel safe. And I want you to breathe in slowly through your nose for 4 counts. So you breathe in, hold, and out slowly for 6. That simple technique calms your nervous system and is just one example of one of the ideal components of a CBTI program. Now, a lot of you might be thinking, that sounds great, but where do I find it? And that's a real challenge because there aren't enough trained therapists to go around. But this is where technology has been a game changer. CBTI is now available in online programs and smartphone apps that deliver the very same techniques. And these aren't gimmicks. A large analysis of many clinical trials found that digital CBTI meaningfully improves sleep, and the benefits were still there a year later. In many studies, the results are comparable to seeing a therapist in person. Plus, it's available anytime. It usually costs less, and there's no wait list. But here's an important caveat. Not all sleep apps are created equal, and there are hundreds out there, and most have never been tested. So let me point you to a couple that do have strong evidence. Sleepio is a 6-week app-based CBTI program. No prescription is needed. If your employer or health plan covers it, it's free. And you can check by taking a short assessment at sleepio.com to see if that's included within your health plan. There's also a free app called CBTI Coach, which was developed by the VA. CBTI Coach is different than Sleepio. It's a free tool that you can grab immediately with zero friction, but it's meant to reinforce techniques that you're learning elsewhere, either in person or through another app. So it's not to replace like a full program on its own. My main takeaway is look for programs that are backed by published studies. So, how do these different formats stack up against one another? Here's the simple version. Seeing a therapist one-on-one in person gives the biggest benefit. Live video sessions with a therapist via telehealth works just about as well. Group programs are also strong. And app-based do-it-yourself versions give a solid, meaningful benefit that's just a bit smaller. The bottom line is that they all work. So a smart approach is what we call stepped care. Start with an app. If you need more, step up to telehealth or an in-person provider. There are a few paths to get started. The first and the easiest is asking your provider for a referral. You can also try one of the evidence-based digital programs such as Sleepio or CBTI Coach, which you could access tonight if you wanted to. Ask about telehealth, which works as well as in person. And you can find a specialist through the Society of Behavioral Sleep Medicine at behavioralsleep.org. I usually tell people to call their insurance company as well to kind of understand how to get connected with the right resources. Typically, that information in conjunction with some help with either your sleep team or your primary care provider can point you in the right direction. The good news is that access is improving fast and more insurance plans are covering these options. Now, I've spent a lot of time on the non-medication approach because of how well it works, but I don't want you to hear me say that medications are bad. They do have a role. Medications can help when CBTI alone isn't enough, or as a short-term bridge to get you through a rough patch while the behavioral techniques are taking hold. The key is that this should always be a shared decision conversation between you and your provider. And in fact, some people benefit from a combination of CBTI with medication if needed. Think of medication as one tool in a larger toolbox, not the whole solution. Okay, so let me give you a very quick high-level tour of medication options. Not so you can prescribe for yourself, but so that you know what your provider might discuss with you. First are the FDA-approved medications, and those are the ones that I've included in this table on the slide. There's a newer class called DORAs, names like Belsomra, Dayvigo, and Qvivic, which help with both falling asleep and staying asleep, and are generally pretty well tolerated. There are the so-called Z drugs, Ambien, Lunesta. Those are meant for short-term use and carry risks like next day drowsiness, falls, and dependence. There's low-dose doxepin, which is good for staying asleep with minimal side effects, and Ramelteon, which helps with falling asleep and also has a lower risk profile. There's also a whole group of medications that providers sometimes use off-label, meaning that they're FDA approved for something else, but can also help with sleep problems. So I just want to do a really quick run through of those, which you may have heard of or be familiar with. Trazodone is a very common one. The evidence for trazodone as a sleep medication is actually pretty limited and is mostly helpful when people have sort of concurrent depression on board as well. Mirtazapine can make sense when insomnia comes along with depression or anxiety as well, but it can cause weight gain and is sometimes used in that setting as well. Gabapentin or pregabalin, also called Lyrica, may help when there's chronic pain in the picture. And quetiapine or Seroquel is sometimes used, but it carries enough risk that we really reserve it for people who also have a psychiatric condition that it's meant to help treat. This is a non-exhaustive list. I'm sure there are all kinds of medications that doctors have noticed can help with some sleep problems, but are really FDA approved for something else. The main point about this whole off-label group is that they're generally best when you have another condition that the same drug can help with. And one important caution that ties back to earlier, some sleep medications can worsen sleep apnea, which is another reason why we like to sort that out first before getting really into the weeds on insomnia treatment. Every one of these medications has trade-offs, which is exactly the kind of thing to talk about with your provider. Okay, so let's talk about things to be careful with. And I suspect some of these will hit home. And I'm not here to judge. These are all understandable things to try. Sleep troubles are very distressing. But here's what the evidence shows. Over-the-counter sleep aids, the PM products and Benadryl type medicines, they can leave you groggy and especially in older adults cause confusion. They're not good long-term solutions and I typically don't recommend them. Melatonin is very popular, but the evidence for chronic insomnia in adults is actually pretty weak. Alcohol might help you fall asleep, but it does fragment your sleep later in the night and makes insomnia worse. Benzodiazepines, such as Ativan, Xanax, Valium, Klonopin, these all raise the risk of falls, confusion, and memory problems. And cannabis or CBD, there just isn't really good evidence yet, and the guidelines don't recommend them for insomnia. So if you're relying on any of these for your sleep, it's a great conversation to have with your provider about better options. Okay, I want to spend a minute on a group that struggles with sleep in a very specific way. Women going through perimenopause or menopause. If that's you or someone you love, this part is worth hearing. Sleep trouble is one of the single most common complaints during the menopause transition. Depending on the study that you look at, somewhere between 40 and nearly 70% of women have sleep problems during this time. And up to 4 in 10 actually meet the diagnostic criteria for a sleep disorder or insomnia disorder. So if this is you, you're absolutely not imagining it. Why does this happen? Well, there are two main drivers, really. The first is what you would expect. Hot flashes and night sweats make you quite uncomfortable at night and they disrupt sleep. This is probably the leading cause of waking up in the middle of the night. But the second is just as important and often overlooked. And it ties back to the drops in estrogen and progesterone, which affect your sleep directly, not only through hot flashes. So even women who aren't bothered by night sweats or hot flashes can find that their sleep is falling apart during this time in their life. The most common pattern is waking up during the night and then struggling to fall back asleep. Now, here's the encouraging part, and that this is very treatable. The theme continues. CBTI, the therapy that we've already talked about, is still the first line treatment, and it works well here too. Beyond that, hormone therapy can genuinely improve sleep, especially when hot flashes and night sweats are the thing that are wrecking your nights. Though it's not right for everyone, it does have real risks and clear reasons not to use it. Hormone therapy is a personalized conversation to have with your provider. Often, simply getting the hot flashes under control can improve sleep on its own. And one more thing to keep in mind: sleep apnea actually becomes more common after menopause. So it's worth making sure that that isn't part of the picture, too. The bottom line is that menopause related insomnia is treatable and it's very real. Talk to your provider about trying CBTI and about whether hormone therapy fits your situation. Okay, so let's bring it back to three things that I want you to walk out with tonight. Number one, insomnia is common. It's a real medical condition and it's very treatable. You don't have to just live with it. Number two, for insomnia, CBTI is the most effective long-term treatment. And it's available in person, by video, and through apps. Ask about it. It should be the first thing that you try. And number three, medications can help a great deal, but they work best as part of a bigger plan, not on their own. And try to avoid self-treating with over-the-counter products or alcohol. So, what can you actually do starting tonight? Start a sleep diary, even just on a notepad, and bring it to your next appointment for your provider to review. If you snore loudly or someone has seen you stop breathing, mention that specifically to your provider. Ask about CBTI for insomnia, including the digital and telehealth options. You can download the free CBTI Coach app. And for trustworthy information, you can visit sleepeducation.org from the American Academy of Sleep Medicine. Small steps starting tonight can make a real difference. Thank you all so much for your time and attention this evening. Better sleep really is within reach for most people, and I really encourage you to talk to your provider for more information.
That was great. Thank you. We do have a couple questions online. Melissa online asked, is the eye twitching issue truly connected to sleep disruption?
That's a great question for a sleep specialist. I am not familiar. I think any symptoms that people are experiencing during nighttime are worth mentioning to your provider. I think when it comes to sort of our known sleep apnea related symptoms, they're sort of the ones that we reviewed, sort of the loud snoring, the choking, gasping, waking up. Those are sort of our most common ones. Sleep has and sleep problems and disruptions can have a lot of very unique presentations. So, yeah.
Thank you. And then Kelly asked, how do you feel about tracking your sleep with an Apple Watch? Is it helpful or not helpful because you focus on the negative things it may point on?
That is a great question. As far as wearables go, I think that they can be really helpful for awareness in very similar ways that continuous glucose monitors can be helpful with people who have diabetes in terms of awareness. However, I do caution people about using their wearables as diagnostic tools. They're imperfect, but they can be really helpful at sort of pointing out patterns in your sleep that you may have not noticed otherwise. In general, it's somewhat of a similar method to keeping a sort of manual sleep diary, whether that's, on a computer or written down. The only difference is that it does use some body metrics to input and give you a sort of like sleep quality score. I would use that information in conjunction with a traditional sleep diary that I was sort of referencing, because how you feel really matters, despite what the sleep quality score is given to you when you wake up in the morning. And I think that's a really, really important thing to be cognizant of, is waking up in the morning and then being aware of how you feel and how you feel throughout the day. I answered that question.
Does anybody else have questions? There's a few more online, but I don't want to dominate. So do you have questions, anybody?
Say a little bit more. Oh, I should do this. It's on. a little bit more about the thing they put in your mouth? You said it puts your chin forward, the CPAP alternative. How
Yeah.
does that work?
Yeah, so it really is just a device that sits in your mouth and sort of helps thrust your jaw forward. Again, it does not work as well as a CPAP device, but it is something that very often our sleep specialists will offer as alternatives when people can't tolerate a CPAP, and that is sort of their first line therapy. I've also seen dentists and orthodontists as well talk to patients who have known sleep apnea about those devices. But yes, can be a great alternative for somebody seeking treatment who can't tolerate the CPAP and just want something to maybe improve their symptoms a little bit.
And maybe if you're going backpacking or something, if you don't have electricity for a while, that would be good too.
Yeah, definitely. Yeah. In addition to any of the behavioral, sort of like the positional modifications and things like that. But again, yes, I think that's a very good scenario in which an alternative could be helpful outside of the CPAP machine. Yeah, that's a great question.
That's my problem. No matter what time I go to bed, I'm just like clockwork. I'm like last night I went to bed, was almost 11 o'clock, and I'm awake at 3, 4 o'clock in the morning, and then I'm up. I mean, because I normally get up at 4 o'clock no matter what time I go to bed.
Yeah, that's a great question. And it's subjective. There is no too early. It's really about how you feel. So some people just have a lower sleep need, meaning that a couple hours a night, especially as we age, becomes very typical as long as you feel okay during the day. Where waking up too early becomes a problem is when you're starting to have symptoms during the daytime, kind of the ones we talked about, the grogginess, the fatigue, the morning headaches, that kind of stuff. So it really depends. There is no sort of ideal time. I mean, in general, we all sort of work on this 24-hour cycle, right? And there's sort of our all like universally understood daytime hours and nighttime hours. But again, some people just have a lower sleep need. So I would really sort of try to understand how you feel throughout the day. And if you don't feel well, that is definitely something to talk about with your provider and something that could potentially be fixed by one of the treatments that we talked about.
Okay.
We have Mohammed asked about Ambien. Somebody who's been on Ambien for years, is that a problem? And if you've had sleep trouble for over 10 years, is it too late to try CBTI to help?
Yeah, those are both great questions. So I'll answer the second one. So it was if you've had sleep troubles or insomnia for over 10 years, is it too late for CBTI? And the answer is no. That's actually the perfect person for CBTI. It is never too late to start CBTI. It will work, and it works the same no matter if you've had sleep troubles for a few months versus a few years. And then as far as being on Ambien long term, really the biggest concerns with Ambien are the side effects. So the daytime grogginess, the dependence, the falls, and the risk for confusion. And so for many people, that's sort of where I would encourage them to talk to their provider about whether or not there's a safer alternative. And I, as a disclaimer, would not recommend if anybody is on any of these treatments to stop altogether, right? There are risks to stopping your current treatment without talking to your provider. So, but yes, there are real side effects with Ambien that are worth talking to your doctor and having a conversation about exploring safer options if those are suitable for you.
What about a BiPAP?
Yeah. Is the question about where does the BiPAP fit into all of this?
I'm thinking so.
Okay. So CPAP machine is a machine that provides positive pressure. And that is probably the most common machine. Depending on the severity of your sleep apnea or the type of sleep apnea that you have, sometimes a sleep specialist will recommend a different machine that is not a CPAP called a BiPAP. And that's sort of a bi-level positive airway pressure device. And so that's not something that I typically manage in my clinic. That is definitely something that my patients who do need BiPAP, we have a sleep specialist on board, but definitely is the recommended treatment for some forms of sleep apnea.
We have one more. Can you mention the different kinds of apnea?
Yeah, there are two. There is obstructive sleep apnea. That's far and away the most common. And then there is central sleep apnea. Central sleep apnea is a little bit more difficult to diagnose. And that is one that typically I will have a sleep specialist help us out with sort of parsing through. Central sleep apnea can happen in people very often who do not fit that like textbook picture of what you imagine somebody who has obstructive sleep apnea would be like. So can definitely affect younger individuals, can affect women and men, can affect people who are not overweight. So yeah, that one's just a little bit more of a difficult thing to diagnose sometimes. But again, is treated much in a very similar way that obstructive sleep apnea is.
Is there any evidence that putting pressure on acupuncture pressure point would help you fall asleep more quickly, just like deep breathing does?
Yeah, that's a great question. For a lot of our like more holistic treatment options that are available, there isn't really great evidence. I will say sort of in the same way that like, you know, a lot of people find benefit from like weighted blankets or white noise machines, the risk is generally pretty low. So again, I always encourage people to talk with their provider just in case there is an additional risk to utilizing acupuncture. But I definitely think that there are studies being done about other like sort of alternative methods for relaxation that would sort of fit into the curriculum of CBTI outside of the ones that we talked about.
Thank you.
Thank you, Doctor, for this presentation. It's very helpful. I have actually a couple of questions. The first one is, how many sleep specialists practice here in the Flagstaff area?
Yeah. Oh, yeah. So we have 3 providers. We have 1 physician, we have 1 physician's assistant, and then we have a nurse practitioner, correct?
And by we, you mean the hospital?
The hospital, yeah, here at Northern Arizona Healthcare.
We also have one down. We have a nurse practitioner, our physician assistant down in Cottonwood as well.
Another question. How much or how little does taking a nap in the afternoon fit into this problem?
Yeah, that's a great question. In general, naps aren't bad, but they can lower your sleep drive. So I usually tell people that if they find that the naps can be helpful and restorative, to try to schedule it earlier in the evening or earlier in the afternoon or late in the morning so that it still allows you to build some sleep pressure during the remainder of the day so it doesn't disrupt your nighttime sleep.
To be something that affects like the quality of your sleep, how in Flagstaff it's just harder to breathe in general?
Absolutely. So 100% in terms of sleep apnea. Being at 7,000 feet at this altitude definitely makes sleep apnea treatment a bit more complicated, and we definitely see that with our patient population. As far as insomnia in general, it really depends on your other health conditions. So depending on what other risk factors you may have, if they are at all affected by the altitude, that could definitely contribute to some sleep problems.
For those of us that know someone who might be interested in this information, will it be online later or taped?
It will be. So we will add this presentation to our YouTube channel.
Okay.
So you can go back and look at it from there as well. Watch it.
Okay, and the name of the YouTube channel?
It's under Northern Arizona Healthcare.
Okay,
Mm-hmm.
thank you.
And I know if you signed up in the back, we will be able to send this link to you or send you the link to it as well. Email it to you.
Mental health affects your insomnia?
Absolutely. It absolutely does. Particularly in the way of particularly in the way of what we call sleep onset insomnia. So that's difficulty falling asleep. Definitely can affect still like difficulty maintaining sleep as well. But I would say more often, poorly controlled mental health has the biggest impact on falling asleep. And that is definitely one of the things that I screen for or talk to patients about to try to optimize, because again, can be a more direct treatment than some of our other sort of sleep medication options. And also that's where CBTI can also be helpful as well. There's lots of different cognitive behavioral therapy. The CBTI is specifically for insomnia, but sometimes you may hear your provider mention cognitive behavioral therapy for other sort of mental health conditions, which can be helpful. And they definitely are somewhat interrelated.
When I wake up in the middle of the night, my brain just going. The only solution I have is to go out and do some push-ups and stuff and then get back into bed again. But is this a usual thing? And is there just a way of counting sheep or something that can set my mind more at ease?
Exact type of situation that CBTI aims to help with. So the sort of going back to the 5 key principles, trying to retrain your brain to only link the bed with sleep, trying to limit the amount of time that you spend in your bed, and then trying to utilize relaxation techniques. CBTI is not something that I recommend doing without a provider. That's why we have trained therapists that provide this program, because for short term, you are limiting your sleep, which depending on your medical history can sometimes be dangerous. For most people, it can just be a really rough patch to get through. And so that structured sleep consolidation process can be very, very helpful for sleep maintenance and trying to minimize nighttime disruptions and then allow you to fall back asleep when those disruptions do happen so that it doesn't have such a dramatic impact on your night and then subsequent day.
Sorry, I was late. I overslept.
No, that's okay.
Just kidding.
These are all great questions. Thank you guys.
Yes, so and thank you again for all the information, because I have my spouse that for years, I felt like I was sleeping with the bear. It was constant. I couldn't even sleep because he would constantly fast and you would stop it, go to sleep. And so we both went for our doctor and saw our physician and recommended that we need to make some lifestyle changes as far as our eating habits, because our medical was kind of not getting where we wanted it to be. And now it's day and night. So the loss of the weight has helped.
Absolutely.
I would like to sleep on the opposite side of the bed, or I'd have to sleep in the other room. And even my mother would hear, "Oh my goodness, how can you sleep at night?" Because he was just so loud. But anyways, it's been like 6 months now, and it's just, I can sleep, even though I have a hard time sleeping at night. And I don't know if it's just because I drink water all the time, that I get up 2 or 3 times in the middle of the night, and it's like clockwork. And it's been like this for, we're going to be going on 6 years since I went cold turkey without drinking soda on Thanksgiving morning. So I feel like I'm a faucet, right? But yeah, that's, so I don't know if that's part of, that I maybe need to see
Yeah.
my physician.
So there, in the way of obstructive sleep apnea treatment, there's a reason why some of our GLP-1, those injectable sort of initially diabetic medications now being utilized for weight loss, Zepbound is FDA approved for the treatment of moderate to severe obstructive sleep apnea. And the pathway by which it works, it does not work like a CPAP machine in that it's providing you some kind of pressure to keep your airway open. It's purely helping with weight loss, which can decrease the severity. So although in some cases it's not sort of the end all be all for your treatment of obstructive sleep apnea, it can be very helpful at minimizing the severity and disruption to others in the room. And so it's been a real game changer in the world of sleep medicine, Zepbound, I mean. And then another thing that you sort of brought up, which sort of the reasons why people wake up at nighttime and then due to that sometimes then have a hard time falling back asleep. One of the things I talk about often with patients who find themselves waking up to urinate multiple times a night, and that can be due to a variety of things, both in men and women, particularly as we age, is trying to analyze how you hydrate and when you hydrate. And so if you notice that you're waking several times a night to urinate, potentially I would kind of create a cutoff time to stop hydrating. So meaning, same total hydration during the daytime, but just cheat more towards the earlier part of the day so that you have time to empty your bladder and that isn't contributing as much to nighttime wakenings. But I will say insomnia, regardless of what wakes you up at night, sometimes makes it difficult to fall back asleep. And that's where sort of these behavioral modifications can be really helpful as an adjunct to other things. Yeah. Yeah.
Would you give to somebody who has a family member or a loved one who is, I guess, in denial about the fact that sleep is such a big factor of your health and quality of life?
Yeah, that's a really tough conversation to have. And I find it's difficult for a lot of reasons. I think it's difficult because, depending on the person that you are, referring to, we live in a society that really prioritizes productivity and sort of like this health maxing and really trying to get, utilize every second of every single day. And in some cases that can contribute a little bit to sleep difficulties. My best advice would be really trying to focus on some of the long-term complications that can come from untreated insomnia or sleep apnea, depending on what their situation is. These are very, very real things. I mean, all of us, I'm sure, after a rough night have felt impaired significantly the next day, whether that's, impaired in the way of driving or not being able to do the things that we need to do for the day at work or with our children. And so I find that could be a good place to start. At the end of the day, sleep is sometimes a very difficult thing to show somebody that it's important, but it really, I mean, it's the only time our body has really to do some really significant restoration. So yeah, I think I would focus on that sort of the long-term health consequences. A lot of the times in my clinic, when I kind of talk about, for instance, sometimes people will come in with high blood pressure and we kind of do a lot of back and forth. We kind of go through their history and it looks like they have a pretty high risk for sleep apnea. One of the things I will talk about is that if you do have sleep apnea and we do treat it, that is there's a possibility that will lower your blood pressure and we can avoid starting a blood pressure medication. And so I try to sort of navigate it that way. And in a similar way at home, having those conversations with loved ones about, for instance, their sleep apnea, that it does increase their risk of strokes and it does increase their risk of having high blood pressure. So yeah, that would be my best advice, but they are tough conversations to have. I know from personal experience.
I had a roommate once who was a nurse, and it seems like healthcare providers are sometimes really deprived of a work schedule that allows good sleep. My father was a doctor, and the phone would ring in the middle of the night or during dinner. Um, so, uh, but I think it's getting better that we don't expect interns to work 80 hours a week, or maybe not 100, just 80. Could you talk about that and how healthcare providers are taking care of their own health?
That's a great point. As somebody who just finished residency not that long ago, it's very fresh in my mind about how much we don't prioritize sleep. And I agree, to your point, it has improved. A lot of programs, pretty much universally, have work hour restrictions now, which don't allow you to work after a certain, number of consecutive hours. Now that's imperfect, and I will say there are ways that programs get around it, but that is becoming fewer and far between rather than the norm. I think in a lot of ways, healthcare providers are probably expected to kind of deprioritize their own health to be present for their patients, and particularly in areas that are limited by access as well. So, when you're the only provider for a large community, it can be really difficult to kind of prioritize yourself when so many other people need you. The reality is that as providers, we know the importance of sleep. And until the standards sort of change across the board between surgical and non-surgical residencies, I think it'll be challenging to find that everybody will be operating under like ideal health conditions, but it is getting better. There are lots of conversations around that and a lot of people advocating for themselves and for their health. Yeah.
Well, thank you so much for tonight. We really appreciate it.
Yeah.
That was awesome.
Yeah, I was happy
And
to
thank
be
you
here.
guys for coming. Thank you so much. Our next presentation will be next month down in Cottonwood. It'll also be available online, and we have Dr. Randy. I can't even remember. Noghrehchi, thank you. He will be talking on afibrillation, AFib and the fast and slow and the eradication of our heart, and talking about AFib. So we will get that information sent out, and we look forward to hopefully seeing some of you guys online. Thank you so much for coming tonight.